Let's get to it. Who here knows who that is? That guy posing as a calm professor. Yeah, so someone here got it right. Hamza Chimaev. Hamza Chimaev is one of the main contenders for the middleweight championship belt for the UFC. And very fast in the UFC, he got to a really nice record, 13 wins, 0 defeats. Late 2020, he had some problems with Corona and its complications, and a couple of fights got canceled. That's why when his fight with Robert Whittaker got announced by the end of last week, we had the question, is he fake or is he the real deal? Very few minutes into the first round, Chimaev got Whittaker in this move that's called a face crank. You see his Hamzat's forearm in front of Whittaker's face. This is not fully locked in, but the force was enough to cause immediate pain, and Whittaker had to tap out immediately. Do you see how fast he taps out? And because Whittaker is not, he's a veteran, and he wouldn't like to be called a phony, they released this footage. That's his mandible, that's his mouth. Which brings us to our topic today, traumatic dental injuries. They represent like 5% of the total number of traumatic injuries that humans suffer. However, this small percentage does not make us undermine its importance. Because TDIs, they usually happen early on in life. The age range that's most commonly affected by TDIs, it's like 8 to 12. So the victim has usually have the rest of their life to suffer from the consequences. There is another age span, which is 2 to 4, while a kid is or a baby is learning to walk. But that's usually for deciduous teeth. Boys are affected more than girls, twice or thrice, depending on the community, depending on the sample. And if we get anyone from the street and ask him, like, look at that picture and have a guess which tooth is the most affected, they'll probably guess right, the maxillary center. Causes vary: accidents, falls, contact sports, they vary wildly. There are also social factors, different elements that contribute to the epidemiology. For example, guys at a certain age, they get more into contact sports, so they're more prone to that type of injuries. On the other hand, girls and women, certain ages, sadly, they're more prone to domestic violence. So it's extremely important that you're able to observe signs that you can tell. So within, of course, boundaries of legalities, you can be able to report such incidents and, help a victim. There is also the element which sport is more popular culturally, like American football in America. In Kazakhstan, Dagestan, that part of the world, there is sambo and wrestling. Predisposing factors, some are anatomical. For example, an overjet exceeding 4 millimeters. This would cause the front teeth to be more prone to injury. The probability that a trauma causes injury would be higher. There is also anything that makes the lips less competent, such as a mouth breather with their mouth always open. Because the lips, they act as a cushion. Many incidents, they absorb the trauma, and the injury is just something like a laceration or something to the lips, and they protect the teeth behind. Another factor is, for example, dentine genesis imperfecta. Whatever makes the dentine defective, less able to absorb the energy of the trauma, would cause the teeth more prone to injury. There are other incidents that can predispose to an injury. For example, during a GA, if the doctor is doing the intubation is not that careful, they can affect, especially the maxillary centrals during insertion or removal. For example, in a war zone where the priority is just doing it now, maxillary centrals can get injured. Drug abuse, some drugs, especially in overdose incidents, convulsions can happen and teeth get injured. Not every trauma is going to cause an injury. The impact of the trauma has many factors that affect the outcome. For example, the trauma can be direct or indirect. A direct trauma, like that cute kid at the left, falling and the teeth are actually getting the trauma right on. And an indirect trauma where you can see to the right, the mandible gets forcefully shut against the maxilla. So the teeth are not the ones actually taking the hit, but they're affected by it. This affects the type of the teeth affected. To the left, you can see that a direct trauma will cause the incisors getting, the anteriors getting, the trauma gets injured, while to the right you can see premolars and molars are the ones getting injured, especially premolars. Can anyone guess why premolars are the ones getting injured? Anyone, any guess? Yeah, they're smaller occlusal table, and the nature of their occlusion against each other has a wedging nature. Early in the previous decade, there was a guy, you probably know him, Albert Einstein. He said that energy is affected by mass and velocity. It's easy to understand how the mass is going to affect the outcome of a trauma, but what about velocity? The higher the velocity, the higher the probability that the teeth are the ones getting affected. The lower the velocity, if the energy is the same, the lower the velocity, probability is higher that the bone and the supporting structures are the ones getting affected. For example, the incident that we saw in the beginning of this lecture, Hamza's arm is not working on a high velocity, but it's about the very high pressure on the very limited area. Even when the velocity is not that big, the teeth were not the ones that got broken, but you can see that it's the segment of the mandibles that got separated, pushed inwards. What about the shape? The sharper the object causing the trauma, the more it is probable that the tooth is going to be broken rather than the bone and supporting structures. Take a look at that. Sword is sharp, and it's easily cutting through the yellow object. But you can see that the supporting sticks, the black sticks downwards, they're not even moving because the object, the sword, is extremely sharp, okay? So the sharper the object causing the trauma, the higher the probability that the teeth are getting broken rather than the supporting structure. Any problems? Okay, let's go to the next point. Resilience. The higher the resilience of that object, the higher the probability that the energy is going to be spread over a larger area. The teeth are not going to be broken, but rather the supporting structures. Take a look at that cute girl. She's wearing a mouth guard. A mouth guard raises the protection like 6 folds the probabilities. But if the energy of the trauma is so high that a fracture is going to happen, God forbids, it is the probability is higher that her teeth are not going to be broken, but rather the bone and supporting structures. Supporting structures, I mean the periodontal ligaments. Cute but strong and independent before anyone starts with that. Next thing is the direction of the trauma. The direction of the trauma impacts the type of the injury that's going to happen, and we're going to talk about that much later. Okay, so now a trauma happened and the patient came to your office. How are you going to manage it initially? First thing is the clinical assessment. You have to take history, and you have to ask certain questions before we start on anything. Keep in mind something that traumatic injuries and their incidence, you're not going to see these a lot. Maybe if you work in some hospital where it's like the medical center of a city or a village, maybe in this case. But if you're just, like you're working in your own clinic or in some private clinic, it's very rare that you get to treat a traumatic injury. However, when it happens, your decisions matter. Everything you do, everything you say, it has an impact on that person forever. Imagine the following: a father with a kid, a mother with her kid, and they're rushing to your clinic, and in tears, they're talking about how their kid, the most precious to them, is hurting, something happened, and a kid is crying and in pain and blood. If you manage this properly, these people are your patients forever. Not only them, their close friends, their families, everyone in their assumed tribe or something. Everyone becomes your patient. So just from a pragmatic perspective, you should know what to do. There are questions to ask. For example, where did the injury happen? Does it matter where it happened? Yes, it matters. Because, for example, in a clean field, it's different from in a muddy, dirty field. For example, asking about tetanus. Did they get a vaccine? Did they get booster doses, stuff like that or not? So you have to ask about that. Also, we already talked about how different factors about the impacting object can matter with what the outcome of the injury is going to be. So it's like you're going to be investigating the patient at least with some expectations. When also matters, because not only because it will affect your decisions, but also because of a very different thing that actually you need to keep in mind, that registering the info and having a good record of the case this protects you from different and various medical legal issues. It's not a must that the trauma is going to present to your office immediately after it happens. A patient can only come like weeks, even sometimes a month or two after the trauma, just because now they're starting to complain. There is a totally other scenario. If you don't have a good record of what happened and how the patient was presented to you, imagine the following. The same patient who was at the time of the trauma crying and asking for help, like keen on making sure that you understand everything. And that same patient, 2 days later, after the immediacy passed, and they're sitting there at some coffee shop with a friend of theirs who just got their license to practice law, and that friend is like, hey, what about that doctor that you went to? He looked rich, right? Okay, let's say that you went to their office with 60 teeth in your mouth and you left with only 30. Yeah, you have to protect yourself. You protect yourself with good records, of course the consent. The patient signing consents is a very good thing that protects both parties, by the way. It's not just about your rights, it's also about the patient's rights. And of course, and actually this should come first, the idea that you do no harm. You should actually take every decision with the patient's interest in your head. Okay, let's move on. I like very much the cover of this book because it shows how dental issues sometimes are very small and get neglected. But we need to be aware that sometimes, because of our profession, how our minds are wired to look for dental issues, sometimes we miss more important things. Take a look at that patient you see on the screen. If that same patient is in your office now with the tooth, and you're all focused on preserving the tooth, do you think if this patient says, yeah, but I have a severe headache, or yeah, but I'm kind of seeing everything blurry, is the tooth the priority now? I guess not, because this patient may be suffering a more serious injury to their brain. Maybe he's having some hematoma, some whatever, and they need to be referred to the hospital immediately. So there are other things to ask about. For example, current medications, allergies, medical disorders. You can't be one of these doctors, like every patient who comes to my office is getting that prescription for amoxicillin. What about if the patient is allergic to penicillin? You can't do that. You have to ask about different issues that can interfere with your plan. Let's assume that this patient is on anticoagulants and he or she is having a very persistent bleeding. And instead of trying to control that in your limited office, maybe you need to refer them to some hospital. So there are other issues that can interfere with your actions, and some of these actually should be your priority. Okay, so now we're done with these questions. Let's start with our assessment. Of course, you thought I'm going to say open the mouse. No, before you open the mouse, there is an extra oral examination. Sometimes, as you can see here on the screen, sometimes the patients are unaware of their more serious injury. Like they can be asking about a certain tooth that they feel is mobile or hurting a bit, but actually they're having bigger issues. Like a patient, for example, when they open their mouth and you find some sort of a deviation in the mouth opening. This is suggestive of unilateral mandibular fracture. So there are other things that you should examine. You should examine lacerations to the head and neck. You should examine the bone contour as well as the TMJ. Now we go to the intraoral examination. Radiographs, when you're examining soft tissues, you should be more careful than most people are. Because sometimes you can find, like the slide you see on the screen, you can see a part of the fractured tooth that's actually lodged into the lips. When you find some missing part of a tooth and the patient didn't find it, and you have lacerations in soft tissue nearby, maybe you have to give attention during radiographic examination for that specific thing. As for dental examination, some fractures are so obvious, like the ones you can see on the screen here, but sometimes fractures, cracks and stuff like that are not that obvious. Sometimes we need help, such as transillumination, for example. Like the one you can see on the screen here. Transillumination, where our teeth are translucent. So supposedly, if you light a tooth from one part, the whole tooth is going to be lightened a bit. But when there is a fracture line or a crack that can interrupt the lights traveling through the tooth, you will find the tooth, the part of the tooth behind the fracture line as dark as you can see here on the screen. discoloring agents also like caries detecting dyes, these can be very helpful. Again, if you suspect a tooth, you can just use them and they're going to highlight the fractured part of the crack line. Anyone here is not following me? Anyone here is not getting what I'm talking about? It's important to keep in mind that any time you're examining a tooth that you suspect, you have to examine the contralateral and the opposing. Let's assume that patient is complaining about a certain tooth, okay? You're examining the tooth, you find mobility. Okay, so you record in your documents that this tooth has grade 2 mobility. Let's say if you examine the contralateral tooth of this same patient and you found that same degree of mobility, maybe that's the standard of their dental hygiene. Maybe they have a generalized problem with their teeth that's not related to that certain tooth, that exact tooth that they're complaining about, the one that got the trauma. Another thing to assess is discoloration. It's very important to highlight here that immediate discoloration, especially slightly reddish or brownish discoloration after the trauma, this is not a definitive indication of necrosis because it can be transient bleeding within the tooth. However, discoloration after the trauma is some time, like a few weeks after the trauma or something like that, a grayish hue like that is suggestive of necrosis, while an opaque yellowish discoloration is suggestive of calcification. So it's important as well to keep track of the tooth's color and how things are progressing in terms of discoloration. Radiographs are, I don't need to highlight the importance of radiographic evaluation. You're in your senior year, so you probably know by now how radiographs are inevitable in endodontics, kind of. Like, it's our eyes, our third eye, as we always say. CBCT is a 3D assessment, but there is a wrong perception here. Like, yeah, it gives us a lot of information that maybe sometimes we can't get with our 2D radiographs, but it's important to note that most traumatic injuries can be examined via the 2D radiographs. When 3D CBCT is indicated, it adds valuable information, sure, but when indicated. The question here that you should ask yourself all the time, am I going to ask for another radiograph? Am I going to ask for another, am I going to request a CBCT? There is a question here to ask yourself. Is this next radiograph or that CBCT I'm going to request? Is there something that I'm going to see that's going to change my diagnosis and subsequently my treatment plan? This is very important because don't forget that most traumatic injury patients are in a certain age group that's very susceptible to the ionizing radiation. Their tissues are very sensitive to these. So it's not like take radiograph whenever you want. It's not like that. You have to minimize these as much as possible. Any problems? Shall I keep going? Okay. Next thing, and it's extremely important, is pulp stats evaluation. I know you got an idea about it in the diagnosis chapter, but I'm going to highlight a few things. There are sensibility tests and there are vitality tests. Sensibility tests can be thermal and can be electrical. In the thermal, these are the tests that evaluate the neural component of the pulp. The neural component is assessed via pain. So in the thermal test, you get a stimulus, cold or hot. After drying the tooth, you apply that stimulus to a relevant part, usually the buccal surface of the tooth in the middle third, where the enamel thickness allows for the stimulus to reach the tooth. The electric pulp testers, this is it for if anyone here didn't see it before. An idea kind of similar to that of an apex locator. I'm talking about being an electrical circuit. There is the cheek or the lip clip, and there is the tip of the device itself that's put on the tooth, and then the voltage increases. And when the patient starts to feel pain, this is when you register the number in front of you. So regardless trauma, if for example you raise the voltage very, very, very high and the patient still feels nothing, the tooth is necrotic. If the patient feels very early on, then this tooth is probably, its pulp is inflamed. Vitality tests, these measure the vascular supply of the tooth. For example, there is the laser Doppler fluorimetry, which measures the blood supply, the blood flow within the tooth. Well, to be honest, since I was your age, and we've been told that it's a promising technology, and it is, but it's still not that widespread. There is also the option of pulse oximetry, which measures the oxygenation of the pulp within the tooth. Again, a very promising technology, but its use is still kind of limited because we don't have dedicated sensors for teeth. So there are like technical issues standing in front of these technologies to be widely adopted. When you take that initial assessment, there are some factors that can affect the reliability of the results. First of these is the stress and anxiety. If you're testing the vitality or the stability of the tooth of this kid, when he screams and he's like, are you sure that he's really feeling pain? Maybe he's just stressed. Maybe they're just anxious. And the same thing, by the way, if they don't report any pain, maybe they're just afraid to show that they are in pain. Another factor is the plexus of Raschkow, or if we adopt the German pronunciation because he was actually German, plexus of Raschkow. Anyway, if you remember from your dentition course, this is a very important part of the neural component of the tooth that affects its ability to sense different stimuli, and it does not get completely formed except 5 years after the eruption of the tooth. So a tooth that does not have its plexus completely formed can report false negative. Also, don't forget that this tooth just passed through a traumatic injury, so this pulp can be in edema. Put these factors together, and we know that the result of the pulp vitality or pulp sensibility test, the initial results are not that reliable. However, we still have to do it. Yes, the temporary loss of sensation is a common finding, but the lack of response is not a definitive indication of pulp necrosis. You have to do it to establish a baseline for comparison. Imagine the following. This patient reported no pain during your initial assessment. If a week later, that patient starts to report pain with that tooth, so it's either that the initial assessment was a false negative, or this is actually a positive thing. The tooth is healing. Okay? So this is the importance of establishing a baseline. Injuries are different. There are many types of injuries. And there are many factors that affect our procedures and how we are going to manage them. And we're going to talk about this in the next lecture, inshallah, tomorrow.